I think we can actually get started. I think people
It's
are
new.
still.
Okay.
It's 12:01. I think that we're
Oh,
good to go.
okay.
People are strolling in. So,
Okay.
um,
Okay.
so welcome everyone to this fourth Arthur C. Rotenberg Suicide and Depression Studies Program Public Series on suicide research. So I'm Sakina Risby. I'm the chair of this wonderful program at U of T and St. Michael's Hospital. And there's some of you who might be joining us for the first time, so just letting you know again that the goal here for this lecture series is that we really wanted this to be knowledge sharing. There's so much incredible research that's being done in the sphere of suicide risk and prevention, and the public doesn't know much about it. So we really want to try to build to bridge that gap. So, also, there's a feedback form that we'll drop into the chat because if there's something you really want to know about, let us know on our feedback form, and we'll try to build that into our monthly talk. So, we're going to be here monthly until June on Mondays, 12 to 1. You can sign up for updates on who's coming next in the link in the chat. And also for this talk, if you could use the Q&A feature that's at the bottom of the Zoom, that would be great. I'll be monitoring that when we do our Q&A. And also, I like to remind folks that, we are trying to inspire here, right? That's a big piece of this, but we are still talking about suicide, even if we're talking about it academically. Just be mindful if that's something that's hard for you to hear today, or for whatever reason, and just try to take care of yourself and do what you need to do. This session will be recorded, so you won't be missing anything. If you kind of take a step away and need to come back, that's totally fine. And I am so thrilled to introduce our speaker today. And we have the privilege of having Dr. Diana Clarke, who is a psychiatric epidemiologist and research statistician, as well as a director of research at the American Psychiatric Association and an adjunct faculty in the Department of Mental Health at Johns Hopkins Bloomberg School of Public Health. She is the president-elect of the International Academy of Suicide Research. She's a certified mental health counselor and a founding member of the Friends of the National Institute of Mental Health, which is an advocacy group for ongoing research funding for NIMH, which includes research on diversity, disparities, and suicide. And a primary area of focus for Dr. Clarke's research involves understanding cultural and ethno-racial differences in the pathways to suicide risk and care. This is such an important topic. We just had this very, very discussion in our suicide intervention supervision this morning, and she's going to talk to us today about cultural humility and how it can strengthen suicide risk assessment and prevention. So thank you so much, Diana.
Okay. Thank you so much for this great invitation. And I also just want to say it was very easy for me to accept this invitation because when I started my training in epidemiology at University of Toronto and wanted to do suicide prevention work, we really didn't have a lot of people in the School of Public Health who had that background. And so the person who ended up working with me and serving on my committee as an advisor was Dr. Paul Links, who was the inaugural chair for the Arthur Sumnerberg Chair in Suicide Studies, and Ron Hesselgrave, who was the VP of Research at the time. And so I feel an affinity to the organization, and so it was really or the institution, and so it was really important for me to do this. So yeah, so today I am going to talk about cultural humility in suicide risk assessment and prevention, and then also share some of the research work that I'm currently doing in this area. So first, I'm going to say I have no financial conflicts to disclose, specifically as it relates to the topic. As Dr. Ritzley said, I am president-elect of the International Academy of Suicide Research. And so therefore, from time to time when I travel for conference, they might cover some of my expenses. And then I am at the American Psychiatric Association. That's where I'm paid, salaried. And so I will talk about the cultural formulation interview, and the cultural formulation interview is developed by the APA. So I just want to put that out there. It is freely available online. And so there's no, as I said, no financial interest, conflicts to disclose, but we always have conflicts of interest in terms of other intellectual stuff. So before I get started, what I'd really like for you to do for me is just answer this question. I'd really like to know my audience. And so, how would you best describe your role in suicidology? That is, where do you spend more than 50% of your effort? If you can just scan the barcode with your phone and answer that for me, that'd be fantastic. Okay. Okay. So I'm seeing that it's slowing down, and so I am going to move on. So this is nice. So I primarily clinicians. We have some advocacy individuals here. Clinician, clinician researcher in training, and primarily researcher or researcher in training. So that is good to know. And so some of the data that I will present will be very research intensive, and so I'll do my best to explain some of the results in more detail, but because of time constraints, I won't spend a lot of time on that, but this is really good to know the audience. So what do we know? We know that suicide is a public health problem, right? So suicide accounts for more than 1 in every 100 deaths in 2021, and that's based on the World Health Organization data. 73% of those suicides occur in low and middle income countries in that period of time. And yet, when we look at research in on suicide and on culture and suicide, we find that it's very limited, and we know that culture matters, right? So here, I'm really just showing the data for the United States, and you can see here where it's actually showing the differences across different ethnoracial groups, and you see the variation in rates of suicide, and this is 2023 data, and how it differs across the different groups, but as well as different age groups, and sorry, not age group, but across males versus females. So we see, even if we just take that one lens and focus on race, that there's a difference. The data for Canada is a little bit hard, especially that there's a lack of data that look at specific ethnoracial diversity and suicide. But we do know that for Canada, about 12 people die by suicide each day, and that it's the second leading cause of deaths in 15 to 34 age group, which is similar to the United States and other countries as well in terms of being the second leading cause of death in that group. And that if you see, whether we are talking about Canada, the United States, but countries with indigenous population, we do find Australia, New Zealand, you do find a higher rate of suicide in the indigenous population, right? And so we know that culture matters, and so it's important for us to actually look at culture when we think about suicide. So I'm going to ask another quick poll here is, do you think culture is important in informing the work you do in suicidology or suicide prevention? Okay. All right, so that's a resounding 100%, so that's fantastic. So, in a research study I'm doing right now, I tend to, in most of the studies we do at the APA, we do try to make sure we do have a lived experience advisory panel or partner team. So I call it my LEAP team. So we're moving forward. And this one individual in the group talked about having had mental health issues, including suicidal thoughts and behavior, since they were about 10 years old. And you would have to hear the emotion in this individual's voice as they talked about how most of the time when they talked about their lived experience, whether it's with just mental health in general or with their suicidal thoughts and behavior, they were never asked whether culture was important. They were never asked about their cultural background or their racial background, and and how whether that was relevant until they were like 50 years old. So 40 years in care with no questions asked about ethnoracial cultural background. Even a question of like, do you find your cultural connection supportive? And if so, how? Do you have someone in your group that you could reach out to if you were struggling, would have been helpful for her? Right. So she said, I certainly feel personally, if someone had asked me about my cultural background, it would have been enlightening earlier than when I was 50. So one of the things I do, because I like to play around with things, and I was just talking to Sakina that I like gadgets, and so I thought, it would be so interesting because Durkheim talked about the importance of culture so long ago, and so I thought it would be nice. Let me see if AI can generate an image, a cartoon figure with Durkheim, Freud, and Morselli having a conversation about the importance of cultural humility. And so here you're Durkheim saying it is essential, Freud is saying not necessarily, and Morselli is saying, I think so, right? And so I'm on the side with, both Durkheim. I'm on the side with Durkheim, less definitely not Freud, because I really do believe that focusing on culture and cultural humility in the assessment and clinical management of the suicidal person is quite essential. So as I mentioned, so Durkheim did his work, and as you can see, back in 1897 when he published the work Le Suicide, he actually talked about the importance of culture. And culture was broad. He talked about religion and different things. And then after that, you see a very slow growth in any kind of research work that included anything on suicide. And then it started to increase. And we are finding that more and more people are talking about culture. And yet, despite this sharp increase that we're seeing, if you look on you're seeing that it's not really a lot that's being done. It's still limited, but even with that limited research, it's a sharp increase from what was happening even in the 90s and the 2000s. And we don't know what will happen given changes and cultural shifts and what's going on here in the United States and other parts of the world, whether how this will impact research on culture. But what we're finding is that a limited research, and so our understanding of how different individuals from different culture and how they present with their mental health symptoms and suicidal thoughts and behavior is really limited. So what I want to ask you is, when you think of culture or apply it in your work, what are some of the factors that you include? What are some of the factors that you think about? And no right or wrong answer, just type it in. Okay. So this is really good. So I'm seeing a lot of different ways that culture is thought about. When I do this in other settings, sometimes language, race, and ethnicity are the three that jumps out. So I'm seeing language, but I'm seeing the religion, beliefs, spirituality, right? So thank you. I'm going to just move to the next slide, but this is important to see that people are thinking broadly when we think about suicide. Or when we think about culture. Okay, great. So we know that it's important for us to think about culture when we do suicide risk assessment, because society and culture play this enormous role in dictating how people respond to and how they view mental health and suicide. Cultural variables have far-ranging impact on suicide. It shapes our risk and our protective factors. It shapes the meaning that one assigns to stressors, and which can affect the development of suicide tendencies. It affects one threshold or of tolerance for psychological pain, and whether that psychological pain would result in subsequent suicidal act. It impacts how suicidal thoughts, intent, plans, and attempts are expressed. It impacts on our willingness to self-disclose suicide risks, so stigma, as we talk about. And when I'm talking about stigma, I'm talking about self-stigma, stigma within one's own culture, and stigma from the broader community or the broader environment. It impacts the availability and types of treatment and interventions that an individual have to reduce suicide risk. So, again, similarly, just continuing to talk about this, as I talk about how it impacts on how suicide is viewed. And so in Western culture, you'll see that you have this more medical or psychological view of what suicide is, right? And so what causes of suicide behavior. And there's a strong emphasis in Western culture on individualism. And so feelings of isolation and personal failures tend to play some key roles in suicide thoughts and behavior. When we think in terms of the Eastern culture, where you have this blend of traditional values with modern mental health perspective, self-harm is seen as a response to intense personal and social pressures, not to negate the fact that biology and other factors play a role, but it tends to have more of this focus on the personal and social pressures. And when we think in terms of the indigenous populations and the history of historical trauma, cultural disruptions, and other socioeconomic factors, and you see how those factors influence the risk and shape experience and expression of suicidal thoughts and behavior in the indigenous communities. And whether that's in indigenous communities, whether it's in North America or in other places like Australia and New Zealand, etc. In the Caribbean cultures, there's transgenerational cultural conflicts. You have unemployment, you have family and social stressors, you have religion, and all these things together, right? So within some of these cultures, they might have large social networks, and a lot of times it's misinterpreted as, oh, this person has lots of social support, and so might not necessarily be at risk, but those social support can have positive and negative effect that can actually, and the negative component of that social support can outweigh the positive component of it, increasing the individual's risk. And I've done some work with data from Canada, the United States, and the UK, and identify some of these things that some groups, the negative social support outweighs the positive social support, leading to increased risk for suicidal thoughts and behavior. In the African culture, and similar in the Caribbean as well, where you have this heavily stigmatized view of mental health in general, but then suicidal thoughts and behavior. And mental health problems and suicidal thoughts and behavior can be attributed to supernatural causes. It's a taboo, stigma, and people tend to opt for traditional or religious healers when they experience these signs and symptoms. And so getting to care is probably problematic. Or at least it requires that in doing some of the work that we do, we might have to focus on these traditional or religious healers for both the African cultures. We see this in the Caribbean cultures as well, in some Eastern cultures, that we have to work with other groups other than healthcare providers when we're trying to reach these populations and engage them in treatment. In the Latin culture, the main focus has been found to be the stress of balancing family obligation with personal autonomy, and acculturative stress tend to play a significant role. And we know religious and spiritual views, where for some group, suicide is viewed as a sin and morally wrong, and so this can be served both as a protective as well as a risk factor. And this when we talk about collectivist society, a person, any kind of individualism might be considered a failure. And so a thought of suicide could be seen as a failure. And so, but then at the same time, these communities can have strong social support network that can actually protect against suicide. And then again, you can also have that negative component of it as well, where it can actually help to increase risk for suicide. So one of the things, culture is complex. That's the reality of it. And because it's so complex and multifaceted, it sometimes make it challenging for it to be incorporated. As I said, most people tend to think of some culture as race, ethnicity, and language, and it's more than just that. It includes information on the person's identity, so their ethnicity, their race, their gender, language, etc. But it also includes information on beliefs, and this was actually included in the poll. So moral codes, the person's value, their religion, ideology, etc. And social structure, right? So family structure, educational systems, social hierarchy within a society, and then a lot also practices, the rites and rituals, dress style, traditions, customs, communication styles, and the interaction of all of these factors can create culture and subcultures within cultural groups. And so when we're thinking about culture and trying to incorporate culture in our assessment and treatment, it's multifaceted and it requires us not to use a one-size-fits-all approach when we're doing this. But this complexity impacts on how culture is operationalized across different studies, right? So there tend to be this oversimplification where studies tend to reduce culture to a single variable. So they might say they have ethnicity, they're looking at ethnicity or race or language or religion. And so because they've done that, they're looking at culture and without actually, explaining that you're only looking at a small component of culture. And so it doesn't capture everything. Right. And then they tend to overlook this intersectionality. And that was also incorporated or included in the poll, where even though you have all these subcultures based on all these other factors, when we look at intersectionality, then we know how age, gender, socioeconomic status, and sexual orientation and the intersection between those then also create even finer subcultures and how important that is. So Black cisgendered person and their exposure to suicide might be different from a Black transgendered individual. And so treating those two as just always two Black person and we treat them the same in terms of addressing their suicidal thoughts and behavior might not be the right approach. So, and then a lot of studies tend to focus on just a single culture, right? And sometimes it's because it's easier to do that. But then when you focus on only a single culture, then it impacts the scalability of the prevention efforts that's been developed. So it's a broad construct. We need to develop more tools and methods to do this and to assess culture. And so that's one of the things that the AP had actually done in developing the cultural formulation interview, where it actually was not a structured questionnaire, but more of a semi-structured interview that allowed the clinician to kind of lead the conversation and work with the patient collaboratively to collect the information that they need. So culture is very, as I said, multifaceted, and so is suicide and the causes of suicide. So we require this multi-pronged approach even from the conceptual stage of a study in order for us to actually tap into looking at culture and suicide. And when you look at even some of the theories and the models of suicide, you'll see that they as well leave out information on culture. So this is the IMV model. So this is the integrated motivational volitional model of suicide, very popular model of suicide. But when it doesn't talk about culture per se, but then when you look at it, you can see where even within the background factors and triggering events, so these are the pre-motivational phase, you can see how culture would play a role, right? In the motivational phase where it's impacted by social problem solving, coping, etc., burdensomeness, resilience, social support attitude, access to means. You can see across the different component of the model how culture plays an important role, right? If you're more biological in terms of how you think about suicide and you think of the stress diathesis model of suicidal behavior, again, here you can see and just kind of highlight where culture plays a role. It plays a role in childhood traumatic experience. It plays a role in the diathesis component of the model, the individual sensitivity to social stress. It plays a role in the stress itself, whether the person have financial or marital problem and exacerbation of their psychiatric problems, and it plays a role in expression of suicidal behavior. So culture plays a role across the model. And I can go across a number of different models and show how the important role of culture, even though it's not specifically stated in the model, but when studies use these models, they tend to exclude that component of culture. So how can we address culture in suicide assessment and care? So here's another cartoon, and I'm going to spend long on it. It's me saying this is what Durkheim must be saying in his mind when he looked down on a conversation being had. I can't believe they're still debating the importance of cultural factors in suicide prevention. And one of the arguments that I do here is that time constraint is the problem, right? And we agree that whether it's clinical or in a research setting, it can be challenging, right? But if we're going to do person-centered care, it becomes important for us to meet people where they are, and we have to focus on and incorporate culture in what we do. And so how we can do that is working together collaboratively to develop a feasible and clinical useful way to do this. That also brings into consideration the voices of people with lived experience. So the DSM-5 cultural formulation interview, it's a brief semi-structural clinician interview, and it was developed and tested during the DSM-5 revision process. And it was developed to help clinicians understand a patient's cultural background and lived experience and how these factors shape their symptom presentation, the meaning they're assigned to what they're experiencing, their coping skill, and help seeking behavior. It was developed to help explore the individual's cultural identity and their explanation of illness, their sources of support and stress, and preference for care, with the goal of improving diagnostic accuracy, therapeutic alliance, and culturally responsive treatment planning. And we know that how important therapeutic alliance can be. And so we thought about how can this be applied to suicide assessment and treatment. So I'm not going to go through all the evidence on the cultural formulation interview, but we found that it's been, the research studies been done have shown that it's clinical, it has clinical utility, and it has shown some effectiveness. It's easy to incorporate in diverse clinical settings, right? Can take 30 minutes, within 30 minutes. Sometimes I've seen where it takes longer depending on the person's symptom presentation. It benefit diagnostic process because it helped the clinician understand the patient's symptoms more and their perspectives when they present, which can actually help to improve therapeutic alliance and build trust and keep the patient more engaged in care, right? And we know therapeutic alliance is really an important mechanism for care outcome. And so we know that this cultural formulation interview can have utility in suicide risk assessment and clinical management. So we're conducting a qualitative study right now where we are using, conducting focus groups with different ethnoracial groups. And here again, we're focusing on race and ethnicity when we pull people together, but then when we meet with them, we talk more broadly about what culture means to them. So these are individuals with a lived experience of suicidal thoughts and behavior who have had a suicide screening or assessment done and have worked with a clinician to develop a suicide safety plan. And so we run these 1.5 hour online focus group via Zoom and ask questions around culture and suicide, what that meant for them, what would have meant if they were asked these questions during their suicide crises, and then also talk about wording and framing of the cultural formulation interview for suicide assessment, which is an adaptation of the cultural formulation interview, working with the developers, so Roberto Luis Fernandez and Maria Kendo, to adapt those questions to for suicide assessment and safety planning. And so we have two independent qualitative analysts reviewing the Zoom transcript and identifying themes across focus groups. And so far, I'm only going to present just a snippet of some of the results, but we've done some focus group with white females and Asian American females. And what we're finding out, that geographic location or where a person grew up has been identified as important concept of culture for both groups, faith or their belief system. Then for the Asian females, they talk about generational issues, right? Culture is something that basically shapes or reshape how we live and how we interact. To some extent, culture for me is passing through the generations. But for the white female focus groups that we've done, that generational piece doesn't come up. And then this whole concept of not thinking about culture only showed up in the white female group, right? So they're just saying, my culture thing, I guess I just never thought about it, right? But even within the white population, they will talk about, but I do know that culture matters to some of my friends from different groups, right? So again, what role does culture or cultural identity play in suicidal thoughts and behavior? And so parental stigma. So the parent being embarrassed or having this stigma in their outlook can impact on whether or not the individual, how they present and whether they will talk about their suicidal thoughts and behavior. And that was across both groups. Again, you see the intergenerational trauma, mostly in the Asian female population. We didn't find it in the whites again. And again, none. I wouldn't necessarily say culture played a role in it. We only found that coming from the white female. And I will say these are white American born females, and we're still running focus groups with individuals that are immigrants, white, female, as well as male. So we're doing focus group with males and females, but separate ones. And with a cultural lens in suicide assessment and safety planning, would it have helped? And is it important? And again, you see both say yes, it's important, but we did have a few white females who say that they didn't think it was important compared to if they were thinking about an African American or Asian person. But when you're doing research and you're using focus group, you're just getting a snippet, right? Because you're using a small number of individuals. So my focus groups are between 4 to 8 people, and I'm doing a bunch of them. So in the end, I'm going to have interviews with maybe about 100 and something people from different cultural group talking in depth, having in-depth conversation about culture. But we realize that that is still limited, right? So there are ways that we can augment this. So for example, if we think of the Asian American population, you have about more than 20 million Asian Americans from 21 different backgrounds. And if we talk about the indigenous population, the Black population, even the white population, you see how vast that is. And then we're only pulling 8 people from there. So when we get our results, you can see that it impacts the generalizability, right? It gives us some information, but it's not generalizable. So one of the things we thought is, you have social media, and so can we use social media data to augment some of what we're doing? And so we got social media data from Reddit, Suicide Watch, and we can see how if we can use it on these 20 million Asian Americans, and we use this data, it can improve the questions that we do ask and improve our interpretation of the information that we receive. So that we're using it in both ways, to improve the questions we ask as well as to improve the interpretation. And so here is just a quick snippet again where we pull data from Reddit. We have over 1 million raw posts, 720,000 posts. We're on 300, and we have pulled those when we remove duplicates and redact some information. And then we ended up with close to 400,000 unique usernames. And that doesn't necessarily mean unique individuals, because we know people can register with multiple username and then delete an account. So we know that might be some duplicates in there as well. And then we use that information and then use some large language model to extract themes in the post, right? And so we were able to identify 1,915 Asian Americans identified their suicide posts, 1,620 Black posts and 1,210 Latine or Hispanic posts, right? And so we did some topic modeling and visualization. And so this is what we've shown. So if we look at the Asian culture, we're seeing that they talk a lot about struggles with their families, racial identity struggles, struggles with ethnicity, struggles with depression. But one of the key and the most important one that the Asian population talk about with academic pressures and mental health. So the academic pressures and mental health and the racial identity struggles and struggles with ethnicity. Those were the two most popular posts. When we look at the Blacks, we're finding that they talk about self-hatred, despair, experience of self, racism and self-identity struggle, racial identity and suicidal feelings among them, and then of course suicide by cop and gun violence, which ties into the socioeconomic problems and discrimination that we identified before in the literature, that those are some significant factors for suicide in Black population. And then when we look at the Latine population, we see challenges faced from being undocumented in America. They talk about life challenges and despair, and then especially not just for their own life challenges, so seeking purpose and overcoming life challenges, but life challenges for the people and the family members they've left behind, and then some chronic depression, suicidal thoughts and behavior, and miss their life challenges. So you can see that the challenges, they talk a lot about the life challenges. But one of the things that's also important, and we found this in our focus group as well, is that people don't talk about problems, they talk about their struggles, right? And so those are some of the words that came out in our focus group as well, and then we're seeing it in the post. So how do we change our language so we talk about struggles, so we're meeting people where they are in terms of how they're understanding and the words they use to explain suicidal thoughts and behavior, or the factors that are leading up to it. So here's when we put all the groups together. So we pull all the groups together and just trying to look to see what are some of the common things that we're seeing. And so the despair and identity struggles, body image, perception, and self-perception issue, racial identity and personal struggles, identity crises, and discontent with heritage. So what the data is showing us is that identity, cultural identity, racial identity matters. It matters to the people who are posting and the experience that they're having. So here, when we look at, take the same data that we have, but here we want to just look at normalized frequency. So this is where you normalize frequency just simply mean that I've taken I've normalized the information that's seen here because I take it based on the number of posts within that ethnoracial group, right? And so you see that among Blacks, Hispanic, and Asian, when I normalize it, so you're making it based on the number of posts they have. You're seeing that Blacks and Asian talks a lot about the body image and self-perception issue. The despair and identity struggles was primarily in Blacks, but you're seeing it in the Hispanic and the Asian population as well. And then familial abuse and emotional trauma, you find that in the Asian population, but you're also seeing it in the Black and the Hispanic population. And then we talk about desire for escape from life challenges. So the words that they use to describe their suicidal thoughts and what's leading up to it, the escape from life challenges. So it's similar among the Hispanic and Asian population. So the result of this just really shows us that culture matters, and that having a cultural lens is important across ethnoracial group. It's not just when we are dealing with a Black individual or Asian individual, a Latine individual. It's across all groups, because some of the data that we're finding, even when we're interviewing even whites from immigrant whites with not having English as a second language, so they're immigrants here, you're also finding some of these struggles and some of these similar patterns. We just haven't shown that data. Culture is viewed differently, so there's similarities across ethnoracial groups, but there are also differences in terms of how they view culture. And so this cultural lens is important in screening, suicide risk assessment, and even when we're planning intervention. So for example, if you have someone in your office as a clinician, and we know that suicide is stigmatized in their population, they have no support from their community or from their family, then asking them a question about who in your family can be counted on for support is going to be challenging, right? And so here's where, for that individual, connecting them with a peer support provider person would be so useful, right? And then also, if we know someone is in a transient situation where they live, then we know we might have to update their suicide safety plan more frequently because their situation might change. So getting that information is really important. And then results from being used that are being used to inform revision for the CFI is, as I mentioned, we have in it question talk about problems, and we found that even within our focus group, people had issues with the word problems, and they wanted us to use the term struggles. And then when we went to this Reddit data set, the Suicide Watch, we're finding that that's the word that's used across the board, across different ethnoracial groups. And then we used the term suicidal thoughts or behavior, and they wanted us to change that word to thoughts of not wanting to be alive or to live or use self-harm, but instead of using suicidal thoughts and behavior. So those are some of the things that we've actually figured out so far, but we continue to do the work. So any work that we do, it's no, we don't do it in a vacuum. It takes a village. And so I have a team of people working with me. So I've got Adrian, who's a psychiatrist and data scientist, big data, and clinical informaticist. So she does a lot of the analysis work for us. Mandy and Nusrat are our senior researchers and research associate, and does a lot of the quantitative, but also importantly, the qualitative data analysis. And then we have consultation with Roberto Luis Fernandez, who developed the cultural formulation interview, Maria Kendo, who's one of the developers of the Columbia suicide scale. And then we have Dr. Pata Sayamoto, who is the lead on our LEAP team, so our Lived Experience Advisory Panel. She's a social researcher, and she brings, and she's one of 12 people who sit on our panel, and she brings a lot of wealth of knowledge to help us interpret the results that we have from the work that we do. And so it's all this group working together to some of the work that we do. And it continues because we're continuing to do our focus group in the new year after the holidays. And I think that was my last slide. So thank you so much.
Thank you, Diana. That was really fabulous. I think you've highlighted so much for everyone to think about. One thing that really struck me about your talk was about how suicidal thoughts get expressed and how that varies across culture. Given there was actually a lot of clinicians in the audience, I'm wondering, like, what should clinicians actually be listening for? If it's not like, life is not worth living, like, what are the things that they should be kind of listening for? And are there other resources where they can learn more about cultural aspects of suicide risk like this?
Yeah, absolutely. And McGill has a great cultural psychiatry program, right? So we know
Yeah.
that Lawrence Kermeyer, who helped with some of the work that we do here at APA, does a lot of work on culture and mental health in general. But I've
Yeah.
seen he's, does some work on suicide as well. But some of the things that people people talk about, and we know this from just general mental health, that for
Yeah.
some people, it's more psychosomatic when they talk about what they're
Yes.
experiencing, right?
Exactly.
They get into that psychosomatic thing. People talk about, I don't want to be here. So if you don't listen carefully to realize that that's their expression of suicidal thoughts and behavior, as opposed to they won't use the word suicide. In fact, in one of the focus group, a couple of the people were so reluctant to even use the term
Yeah.
suicide, and part of it had to do with some of their experience post a crisis when they expressed their suicidal thoughts and behavior and reached out for help, and then got taken to the hospital, but the police showed up, and so they were, put in
Mm,
handcuffs, and so that was challenging. So some of them are just
yeah.
so afraid of using the word suicide.
Yes.
So not wanting to be here, is something that's used, not wanting to be alive, just wanting to go away. So
Mm,
some of the words. So digging a little deeper, what do you mean by going away? What do you mean
mm,
that not wanting to be here is so
yeah,
important to kind of, so you
yeah,
have to just kind of listen and then not just listen, but observe the change in body language as well. When they're saying, I don't want to be here, I just want to go away. I just want to
yeah,
sleep forever, right? So those are some of the words that have been used.
yeah, yeah, for sure. Um, there's so many questions here that people have, so I could like dig into that. And so also, for everyone, if you could throw your questions into the QA function below, that would be really great. But there's some questions that actually popped up during your talk. And one of them was about bringing culture into the conversation based on the cultural background of primary researchers and like I guess depending on who's doing the research and if you have a comment on that.
You know, um, it's it's really how it's true. So sometimes, you go out and you start doing a research study and you're not from that cultural group, and initially you might have that reaction. But I
Yeah.
think it's similar to when you're doing any kind of therapy work. It's how you build that, and I'll use the term, even though it's a research, but that alliance, that therapeutic alliance with that individual. And I will start off by saying one of the focus group, give an example, that was with predominantly the white female, one of the white female focus group. And when it started, it was this, I don't understand this whole thing about culture. I'm an American and that's what I am. Right. And so it was this pushback about culture and thinking by doing a study on culture, you were trying to take something away. But as the
Mm,
focus, as presenting and talking about what culture is and what it means and how no two person are alike. And even if I put two white person in a room and they dig into it and look at their background and all these intersectionality, how different they
yeah.
are, then what we found was that the energy in the room shifted,
Yeah.
right? Because we're really here to understand and to learn more. It's not necessarily saying that your culture is bad or good or bad. We're just trying to understand it more so we can use that information to provide the best treatment that we can, or to do the research the best way that we can so we can collect the right information to inform clinical care.
Yeah, so really curiosity is key, right? And coming from that space and lens and heart space of like, I'm curious to know more about you and what your life experiences are.
Absolutely. And being
Yeah.
honest and saying, you know what? I don't know.
Yeah.
And I'm
Yep.
trying to learn more. And that
Yeah.
vulnerability I find is actually very useful.
Yeah. Yeah. For for the common elements that you were looking at across cultures, you mentioned that struggles, the word struggles kind of came up, and one of the question was there a definition of struggles for groups, or does it change that word? What I guess gets categorized as a struggle, or does the definition of struggle change?
That's interesting. And we did not dig into what do you mean by struggles, and maybe that's something we should have actually done to kind of understand more. And so I like that question because I'm going to jot it down and see. I'm learning from you because we did
Yeah.
not dig into struggles, but it's something that we will do. But yeah, they will talk about, we did something, and people say that I did something, so the more you harp on your suicidal thoughts and behavior and why you did this and this, then what they found was just that it puts them off. But we really need to understand that it's just that everything that was going on in their life and they were trying to deal with became overwhelming. So they were struggling with all of these things and it became overwhelming, and here they are. And
Yeah.
so it's in that context, and you found that it was similar in terms of
Yeah.
how they talked about that.
Yeah. Yeah. Um, there's so a lot of people get assist training. And for
Hmm.
those of you who aren't familiar with that in the audience, like this is training that you can get to kind of learn how to start talking about and supporting someone with suicide risk. And one audience member is asking that, well, they completed assist training and they will often be told that, when you hear someone say, I don't want to be here anymore, that there might be, a prompt to ask directly, are you talking about suicide?
Mm-hmm.
And that's been a
Mm-hmm.
huge shift for this audience member. But that, based on what you're saying, if you're kind of bringing in some of that cultural um, awareness, is that something that you should actually do?
Mm-hmm. And I think yeah, and here again, I say yes, and I think it's it, but how you bring it in is going to be important.
Right.
So when you say you don't want to be here anymore, and especially if you know that suicide is stigmatized in a population, I probably wouldn't jump straight to suicide. I probably would have asked the question, so when you say you don't want to be here anymore, are you saying you don't want to be alive anymore? So I asked
Yeah.
that question first before I
Yeah.
get to the suicide question. So I just throw that one in first. You don't want to be alive anymore,
Hmm.
right?
Yeah.
Because you're
Yeah.
also getting at that.
Yeah, and I think that that's probably even fairly common, even as a clinician, that you don't just go straight into that. You want to get a sense of what you also want to mirror what language other people are using
Mm-hmm.
to for their own
Mm-hmm.
experience that's meaningful for them as well. So I get that there can be sometimes be a disconnect from like this is what you're like ask directly, it's important, but there's other ways of asking directly but using different words.
Yeah, because for some
Yeah.
people, coming out and just asking about suicide is going to get the shutdown. So how do you figure
Yeah.
out, right? And when you're in a crisis, it's very challenging. So I'm not going to say that it's easy to do
Yeah.
because someone is in a crisis, you want to help them now. But sometimes and we heard this in our focus group where people are saying, if somebody come out and ask me certain questions right away, so even just asking about family issues, if that's the struggle someone's having, you want to back off. So you just have to read the room. It's
Yeah.
just the reality, especially in a clinical setting. I understand that in a research setting, you have a protocol and you need to follow it. And
Yeah.
so that might be a little bit more challenging, but that's part of the reason why there should be cultural questions built in to those protocols so that, depending on cultural group, if the person reacts a certain way, here's a different way to phrase that question. So
Yeah.
provide the person doing the interview with alternate, culturally sensitive, alternate way to ask a question.
Yeah. Yeah, for sure. One other question from the audience member is they're wondering about a connection between cultural background and being a person with a disability and how those two things intersect.
And it absolutely does because having a disability then also create that intersectionality. And I know I talk about age and sex, right? But have being disabled and your ablement also impacts on that intersectionality because it's going to impact on your views of the world and all these things as well, and your
Mhm.
access to different types of care. So yes, it is absolutely a factor that needs to be incorporated in when thinking about culture.
Yeah, it's got like that slide that you have on intersectionality and how that creates other subcultures. So it
Mhm,
sounds like
mhm.
there's so many different points there that people need to be mindful of. So for the when you were referring to your research on the Asian participants, was that anywhere in Asia or was it restricted to certain countries within Asia?
So the focus group you're talking about, or
Yeah, yeah,
so the
yeah, that
focus group
focus
right
group.
now is focused on, and the people who have participated so far are Asian Americans, so across the United States. And so
Okay.
some of what we're doing is expanding that work so that we get data from individuals from other Asian countries, being mindful of issues and having to take people's confidentiality into
Okay.
yeah,
Yeah,
because you have those, we have to abide by our IRB. So how much
yeah,
can we go across countries? So part of
right.
what we're trying to do is partner with researchers in different countries where they can take the protocol
Yeah,
and implement it and collect that data, and then we share data,
yeah,
de-identified data. So that's the way that we've been thinking about it so that we're not violating any IRB issues.
Right. Yeah. Another question was around the revised CFI,
Hmm.
whether that's somewhere that where they can access that or if it'll be available soon.
So yeah, so it will be available soon. We're just trying to finalize because the wording we had and some of the comments that we got from our LEAP team, and so we went back to fix certain things. And so here we're just want to get this study done, and then once we have that data, and we will release the revised cultural formulation interview.
Yeah. Okay. I'm curious about this also from like the other side. 'Cause I know there are a lot of clinicians in the audience today, but there's also a lot of people who are advocates or people are experiencing them themselves. And when often a common practice that I have whenever I'm talking to any new client is what's been your experience talking about your suicide risk with a mental health professional or just your experience with a mental health professional in general. And I'm wondering also if you are someone who is interacting with a clinician, maybe who seems to have, let's say, a more linear perspective on how to talk about suicide or what that means. Like, how do you manage that on the other side as the client? If you have any advice on that in terms of like how they should approach that situation,
Mm.
that might be a hard question, but it just like
And,
came to mind. Like,
yeah, that's a hard that's a
yeah.
tough one.
Mm.
Um, so let but can you break it down a little bit more for me? So
Yeah, I mean, people are going to be seeing all sorts of clinicians, and some clinicians, let's be honest, are helpful, and some are not.
we're not right, yeah,
So,
yeah.
and especially when it comes to something like talking about suicide risk, that can be so challenging for people.
Mm-hmm.
And they're kind of maybe finally venturing to say, like, yeah, I just feel like I want to go away. If that gets missed, or unless they say it in a very specific way, it doesn't get attended to.
Mm-hmm. Mm-hmm.
Like,
Yeah.
I'm wondering, what are the options for them, right? Like, I mean, I think one aspect I heard you say are different peer groups and different other resources that they could explore.
Yeah, yeah. So in one of the thing in the cultural formulation interview, interesting enough, it does ask that question, what are their
Mm,
past experience with but the question comes further down, and that's one of the things, interestingly enough, that the focus group participants said, can we move that question up? Because that's so important because that experience kind of shape whether they will disclose information or not. But if
yeah,
they have a caring clinician asking them, what has been your experience, and how has it shaped what brought you here today? How important
yeah,
that is, right? And
hmm,
I know that for a fact because I've had friends and people who have gone in with suicidal thoughts and behavior and from different cultural background and suicide thoughts and behavior, depression, not wanting medication, going in and saying, I want to try this first. Can we do this? And when a clinician is not hearing them, how that can
yeah,
change their trajectory over time in terms of accessing care. And so, when you hear those things, I think part of what I've done, and I've even in the focus group, I was saying that to my LEAP team member, Pata, that my session with the Asian American was so heavy. And I remember her saying, really, I'm surprised because, we normally don't disclose those things so openly. So it's a testament to
mm,
how you gain their trust for them to talk about that. But
yeah,
part of it was really just allowing myself to be vulnerable and say, you know what? Yeah, I've lost people to suicide. So a lot of the times, starting that conversation, say, I've lost people to suicide. I know it's a struggle. I know sometimes, and I put it out there. I know sometimes when you access care, it's not always the best care. So let's talk about what brought you here now and how can we make things better. So when they
yeah,
realize that you're trying to make things better for them and people that come after them, I find it very useful. But yeah, you're right. Some people have very terrible experience, and that session was so heavy because of negative experiences.
yeah.
and helping them to think through that and giving them the space to talk. So that's part of the problem, right?
Yeah.
Our healthcare system is set up in such a way that you get in, you're seeing a patient, and you need to get things done, right, in a certain time period. And it's hard because the person is in a crisis, the person is talking, they've just experienced this traumatic event, because any suicide attempt is a traumatic event. And
Hmm.
even getting to that point where you're thinking about it can be really traumatic for a person, because especially when they never thought they would be ever get there. So that's really hard. And you're having that conversation and you're checking your watch to see if you've reached the time. And that can
Mm.
cause them to shut down as well, right? So
Yes.
even my focus group, it was supposed to go for an hour and a half. It went for 2 hours and I just let them talk. I gave them the space to
Yeah.
talk. Now, when you're in a clinical setting, that's very challenging to do. So it is talk of sometimes I find that, how do you get to that point quicker?
Yep.
And there's no right or wrong way to do it. But I think as long as the individual feels like they're heard
Yeah.
and their experience really matter. And if you can create that for that person, whether you're doing research or you're doing clinical care, that's what really matters, right?
Yeah.
Those
Yeah.
first few minutes to let them feel heard. Yeah.
Yeah, yeah, and to feel seen, to feel valued, like
Mhm.
I think that there can sometimes be I know you mentioned the self-disclosure as well, which is also a culturally different thing.
Very culturally different.
For
Yeah.
sure. It's like definitely depending on who I'm talking to, that makes a big difference. Like if I'm not disclosing anything, that can actually
Hmm.
have a really negative impact. And I actually don't think it's a problem. I think it's actually very helpful. But there could be
Yeah.
very big cultural differences even in how the clinician actually talks about themselves in sessions too, to kind
Hmm.
of bring that in. But um, I'm conscious of the time and the fact that it's your day off and you you still managed to be here. So thank you so much. And I'm sorry for everyone if we didn't get a chance to get to your question. There were a lot. But really, I think that the take home here is that people experience life in different ways. And I think it's such an important thing to be so curious about that and
Hmm.
not wedded to this idea of a right or wrong way to do things, to talk about things. Like it's just going to be different. And to allow space for that. So thank you so much, Diana, for really highlighting that. The people are loving the talk that you gave out there. Everyone's kind of saying that in the chat.
And,
So
and
thank
I'll
you
say
so much.
and I'll say one quick thing too, only because I've
Yeah,
heard this from patients and from clinicians as well. That sometimes when they approach and started doing things from that cultural lens, they will get that pushback from patient. Why do you want to know about my culture? My culture has nothing to
mm,
do with that.
yeah,
And you know, again, you just have to hear them where they and understand what they're saying and kind of and that's where the breakdown of when I'm saying culture, I'm not necessarily talking about your race. I'm talking about all of these things in your life that makes you who you are. So,
yeah,
when you put it and you phrase it that way, you see how different it is. But when they think you're just talking about their race,
yeah,
then it
yeah.
creates a barrier.
The
It can create a
defense.
barrier. Yeah, it can
Mm,
create a barrier. So it's how you phrase that. I'm talking about everything that goes into making you you, whether it's your
yeah,
race, your educated language, all that stuff, right? Because we're all
yeah,
unique beings. And so once they
yes,
understand that, it takes that edge off a little bit. But yes, but clinicians talk about that. Patients will say, "Why are you asking me about my culture?" Right?
yeah.
And so, yeah.
Yeah, that's a really important thing to recognize as well. Like how you talk about culture can also get people on the defense too. So
Yes. Yes.
yeah. But I love
Especially
what you're
in our
saying.
climate now, right?
Yeah, totally. And I love what you're saying that like I'm just curious about everything that makes you you
Yeah.
is such a beautiful and open space to start from.
Yeah.
So thank you so much for that. And I hope you have a wonderful rest of your day off.
I will, and happy holidays to everyone on
Happy
the
holidays.
who
Yes, to
joined. And
everybody. Yeah.
okay, thank
And
you so much.
yeah, please join us again. We'll be here again on January 12th. I wish.
I
January
know you're
12th.
asking for the
12th.
summer, boy.
I'm
The
asking for
winter hasn't
summer
started
already.
yet. Yes, but
Yes.
yes, thank you so much, and thanks
Okay.
everyone for joining. Okay,
Great.
bye bye.
Happy holidays, everyone. Okay.